So, Assalamu alaikum everyone. Today we are going to do some question solving class. So let's start. I want all of you to participate, try to participate more so that it will be more clear to you, okay? So sometimes when you talk, your brain is more active, right? When you are interacting, your brain that consume the information more and it will be for a long time there, okay? So try to attend with us and try to be attentive also. So let's start. I will start with reading by myself, and then inshallah, if any volunteer from your side, if you want, we can read. The first of all, the thing is that it's for the newer people who are joining with us. So this is actually under a course we are doing. We will do like 12 past papers. So there will be more than 1,200 questions we will solve within 3 months. So we already did 200 questions. So this is our fifth class. We're going to start. Okay. So usually our class is on live sessions. All the classes are. Weekly, we are sitting on Sunday and Wednesday. The days are fixed. The time is actually also fixed. UK time 10 p.m. But during Ramadan, as I have got request from my enrolled doctors, so that's why we just changed a little bit the timing period because of the fatur and the iftar time. Okay. So, but after this Ramadan, our timing will be the same. UK time 10 p.m. It will be on Sunday and this Wednesday. Okay. So this is the introduction and welcome to MRCP Thinking. This is me, Dr. Tanya. So let's just start with
Excuse
our
me, ma'am.
past paper.
Sorry.
Yes, please.
Yeah, please. During this Ramzan month, when is the classes during the weekdays? Is it on?
Ramadan time we will do on same day actually the Sunday and Wednesday, but the
Okay.
timing will be I think it is now 7 p.m. UK time. This is the timing of Ramadan.
Okay. Okay. Okay.
Okay, so
Okay.
only this month the timing will be this. Okay,
Okay. Okay.
so
Okay.
thank you. Okay,
Thank
and
you.
yeah, so this class is open for all, but usually the classes are not open for all. Only who are enrolled to the course, though those people are attending the classes only. But yeah, this is I think the second class I'm taking on opening for all. So let's do. So inshallah, let's see. So first of all, as you know that there is a, if you don't know even how you should start with a question, you should start reading the question from from the word, from the starting of the question first. Huh? Then you will go to the history and investigation. Some people even prefer that from investigation than going up to the history. But for part one, it's okay. Part one, usually questions are not that much bigger that you have to go investigation than to the history. You will feel clumsy. So for part one, you guys, better you should do the question with the options. Please try to read the options also, all the options. Don't just read the question and jump to the question, I mean the history. This is also I myself not prefer. I prefer to read out all the options, even though you know the first one is the answer. Because part one, this is the exam that they will give you very near about options. Then if you jump to the number A and you didn't see the D number, maybe the real answer is maybe the D. So if you don't read all the options, there is a very huge chance you will miss some questions. You will do it wrong, even though you have a very good concept, maybe with that exact question. So I prefer to read all of the options. Okay, this is the first rules. Okay, so let's start. Bismillahirrahmanirrahim. Which of the following is the pathophysiological process with, I think, underline this. So hemolysis of the red blood cell, oxidation of ferrous to ferric, reduction of ferric to ferrous. You know, no? 3 plus is ferric and 2 plus is the ferrous. Shunting due to increased nitrate level, sickling of the RBC. 49-year-old homeless man is admitted to the ED emergency department having taken an overdose of amyl nitrate, which was given to him by a passerby. So on examination in the ED, he was cyanosed. So he is clinically cyanosed, bluish. His respiratory rate is high, it's 30. So he's in a dyspneic patient. Complaints of severe SOB with chest pain also. So not only SOB, there is chest pain. BP is 100/60, it's okay. Pulse is 92, okay, and regular. You suspect they have given you already the diagnosis, methemoglobinemia. So they are asking you, what is the pathophysiology of methemoglobinemia? They have given you the diagnosis. What is it? The pathophysiological process? Anyone?
B.
Oxidation.
Somebody told oxidation.
Oxidation of B, ferrous to ferric.
Okay, some told oxidation from ferrous to ferric. Any other? Anyone else? Anyone else? You want to change the question or you want to stick to there? Any other review? No? Or
It's a reduction of ferric to ferrous.
reduction of ferric to
Ferric to ferrous.
ferric to ferrous. Okay, so there are two things you guys are confused, right? I mean, there is contradictory views are there. So usually the question is that there is oxidation of ferrous to ferric. What happened here in how we are observing the ferrous? We are observing in a us form. This is also one of your question. Okay, they're asking you in which form you are absorbing, our body is absorbing the iron. This is the iron, right? This is the chemical name, that iron, that Fe, right? Ferrous. This is the short form, right? So in a ferrous form, we are absorbing this, okay? So what happened that here actually oxidization happened from ferrous to ferric. That's why this methemoglobinemia is happening. Okay, dear? So this is greatly reduced affinity of our blood cells to bind with the oxygen. So this methemoglobinemia, they cannot be turned to the hemoglobin. Okay, they are usually turned to hemoglobin, but they cannot do. So this methemoglobin is increased. When there are more methemoglobin in your emia means anemia. That means absence of red blood cell, right? Like mia is the word, mia is the whatever this one is after this any word at the ending, that means this is related with your blood, right? So when in the blood, the methemoglobin is more rather than the hemoglobin, this is your methemoglobinemia, okay? And pathophysiology is there is oxidation of the ferrous to ferric, and that's why this methemoglobinemia is happened, okay? So this is the cause, why the cause amyl nitrate. There is also another question. Vice versa, they will ask you what is the cause of methemoglobinemia. They will give you some options and you need to know the causes of methemoglobinemia. All the causes, very important for you guys to memorize, okay? So any kind of nitrates, sodium nitroprusside, and sometimes even you have question with dapsone. You have question with dapsone that somebody has malaria. I mean, not malaria, because of prophylaxis, malarial prophylaxis, somebody took dapsone and they started to have this methemoglobin. So you have a question, okay? So if you don't know about the drugs which are causing the methemoglobinemia, you cannot answer the question. So the causes from methemoglobinemia, very important. And this methemoglobinemia is very, very favorite topic of RCP, okay? So don't skip this one. You have question from dapsone, you have question from nitrates, you have question from sodium nitroprusside, you have question from cotrimazole, trimethoprim, that one, okay? And that this one, this amyl nitrate. Anybody knows amyl nitrate, another name? What is this?
Sodium nitroprusside.
No, this is not the sodium nitroprusside. This is the party popper.
Methylene blue. Methylene blue.
Methylene blue is the antidote.
Oh,
This is
okay,
the
okay,
cause. Okay, dear? This is a cause. This is a cause that will cause this methemoglobinemia. And what you are telling, that one, okay, very good that you mentioned about this methylene blue. What is the treatment of methemoglobinemia? Another question. Methemoglobinemia or ascorbic acid? If both are given, methylene blue or ascorbic acid? Which one you will choose?
methylene chloride.
Okay, somebody told IV, you will go for IV methylene blue. And you will not choose ascorbic acid. But if I'm telling both are the treatment, how you will differentiate? And you will get both of the treatment options in your question.
One is the treatment for congenital cause, other one is for the acquired cause.
Excellent. So congenital cause, if they're giving you that this is because of the enzyme deficiency, Okay, this reductase deficiency, that NADH methemoglobin reductase deficiency from childhood, she's having this as a congenitally. Yes, that time ascorbic acid, it is their treatment. And if something like that iatrogenic, like from outside, they're taking something and happened secondary. This is not primary, secondary, not congenital. Then your treatment is methylene blue. Is it clear? Both are the treatment, but you need to pick from your question what they're asking. If they're asking for your congenital methemoglobinemia, your treatment is ascorbic acid, okay? And if they're asking you that what is the treatment of secondary or acquired methemoglobinemia, like this patient, he was taking party popper. He was not taking, somebody was giving him as an overdose to maybe rob him, okay? So this treatment, this patient, specifically these homeless people, we will treat with IV methylene. Clear? Clear or not? Yes or no?
Yes, ma'am.
Yeah,
Yes, yes, yes.
Okay, because if you are not responding, it's like I'm talking alone. Okay, next. And if you are wasting time, I will be late. You guys will be late also. We don't have much time. We have to go a long way. We need to solve 50 questions at least today. Okay, so I will now shut down this methemoglobinemia. Any question?
What is the another name of that amylene nitrate?
Am I party popper?
Popper.
Am I party
His name
popper?
is Popper.
Pop up.
Yeah, Popper. Yes, Popper. Yes.
Party popper, okay? Sometimes in the party, people are using it to be, it's like an addictive agent, okay? They're feeling happy. So party popper, another. Clear? Any other question?
No.
If, okay, so let's go. Let's go from here to our. Screen hand. Okay. Now, which of the following is the most appropriate next stage? Add digoxin, add ivabrudine, add valsartan, change lisinopril to sacubitril valsartan, increase furosemide. So they're asking you about adding drug. Okay. So now come to the question, 58-year-old man. 58-year-old man come to the cardio clinic for review. He has cardiac failure, heart failure patient. Okay, they have told you as a result of previous viral cardiomyopathy. He had a previous viral myocardiopathy, then eventually he had the heart failure. And recent ejection fraction, EF, on echo is measured 25%. He complains of persistent lethargy and SOB on minimal exercise. Current medication include lisinopril, that means AC inhibitor, and usually the doses I'm always omitting because I don't need to know. Okay, unless otherwise if there is something that you need to dose up. So lisinopril, AC inhibitor, bisoprolol, beta blocker, furosemide, diuretics. His BP is 122/80, pulse is 64 regular, all are fine. He has bilateral basal crackle, so there is some water in the chest, auscultation on the chest. Hemoglobin, it's okay. WBC is 7, okay. Platelet, okay. Sodium is 140, okay. Potassium is okay. Creatinine is just mild high. Chest X-ray, it's like cardiomegaly, prominent hilar vessels because of the heart failure. Okay, so which of the following is the most appropriate next step? So what they're asking here, heart failure patient, he is on some medication already, and they're asking you as he is still symptomatic, so step up the heart failure treatment. What you will do, he's taking SCA inhibitor, he's taking beta blocker, he's also taking diuretics. Now, what should you do?
Add digoxin.
Change lisinopril to
We will
sacubitril.
Add,
change lisinopril to sacubitril
D.
valsartan.
Lisinopril
Lisinopril and
and
sacubitril valsartan. D.
Okay. So digoxin usually, if you are thinking of digoxin in heart failure, usually digoxin is a very good thing, but usually cardiovascular outcome not that much good, and heart failure, when it is heart failure plus AF, this type of patient, we are preferring digoxin more. So usually if in your question, if there is no AF, not irregularity, look at the pulse, you will not go for the digoxin. This is the third line, right? So third line, there are options that should you go for digoxin or ivabrudine or this valsartan or this CRT. cardio resynchronization therapy, right? So these all are third line, but you need to choose according to the patient's condition. Okay, so if patient is not with AF, usually we are not going for this digoxin. So digoxin here we are not using. Okay, you all, most of the people, they have uttered this one. Why not you choose ivabradine? If I'm
Because of
telling
pulse rate, because of pulse
Because
rate.
of
Pulse
heart
is
rate.
Because of
Heart rate
70,
is more than
yeah,
75.
75 that
excellent,
time.
Yeah.
excellent. This is if the same question, if the same question, if the patient was with pulse 80, what you should be your choice? The same question.
Add ivabradine.
Excellent. That's what I wanted to ask. Because ejection fraction for EVA and for sacubitril were both same, right? Both is what? Both less than
Less than 35%.
35%. And look at this question.
35%.
Look at our ejection fraction. So he can go for both. Then you have to choose according to your heart rate. So heart rate is telling you go to sacui, not to the EVA. Okay. So heart rate will differentiate at the later stage. So this is why we will do for your lisinopril to sacubitril and valsartan. There should be, as SE inhibitor should be washed out after stopping. After washing out period, we will give for this one. So anyway, this is the thing I wanted to tell. I don't. If any one of you want me to read the explanation, I will read. Other than that, I'm skipping because the same thing I'm telling. I mean, more explanation, not even there. So let's just read. First, ARB combined with neprilysin inhibitor, sacubitril valsartan significantly improves symptoms and risk of CVS death, combined heart failure hospitalization, death combined in the para. This no need. This percentage, these are extra things. You don't need to burden your head. Whatever you need, I already told you. Okay, go to the next one. Which of the following is the most likely diagnosis? Acute schizophrenia, cocaine-induced psychosis, manic episode, Pick's disease, and viral encephalitis. 52-year-old man is brought to the emergency department by the police. So he was a prisoner, right? He has been found outside the local secondary school shouting that, oh no, okay, he's not a prisoner. He was brought to the emergency department because he was shouting outside of a local secondary school that he can protect the children from access to alcohol and drugs. He has dressed himself as a priest. Past medical history of note include episode of depression. He was a depressive patient and drug use. He has been taking fluoxetine for the last 4 weeks after splitting from long-term partner. So he had a breakup. So that's why he was depressed. And doctor already given him fluoxetine, which he's taking for last 4 weeks. Now, general physical examination and routine bloods are unremarkable. There's no organic cause. So obviously this is a psychiatric cause. You note obvious pressure of speech and clang association while speaking to him. So what you are thinking?
Manic episode?
Many.
Okay, there is one manic. Anyone else? Anything?
Cocaine-induced psychosis.
Cocaine-induced psychosis.
Cocaine induced. Okay. Anything else you want to go for?
Acute
No.
schizophrenia.
Okay, somebody told acute schizophrenia. It is not viral encephalitis. This one, all of you are sure, right?
Yeah.
There is no fever. There is no consciousness level dropping. So it is not your viral encephalitis. You should exclude like this. Whenever there is confusion, it's not a direct question and you are confused. Obviously, you need to exclude each and every option. Okay. Then come with the Pick's disease. Pick's disease. Pick's disease, usually they're having like dementia. Okay. There something cognitive impairment also. So it is also not there. So this is usually frontal lobe dementia. They are coming with memory loss. They didn't tell about him that is memory loss. Okay. Cocaine induced, if it is cocaine induced psychosis, they may be given tachycardic, or they must tell you that there is a history of taking of cocaine also, or maybe he is used to taking some drugs. Okay. So this is also not coming with your cocaine. Okay. And there is delusion of grandiose. He's thinking himself, he's someone that he can do miracle. He can stop all the children from stopping taking that alcohol. He can stop that. So he is feeling himself so higher, someone who is having some powerful person. This is a level, I mean, this is a thinking. We are telling this delusion of grandiose. Okay, or delusion of grandeur, whatever you told. So it's a kind of delusion that people when they're thinking that I'm someone very special or I have some power that I can do that. So usually cocaine-induced psychosis, you will not get that. Okay. So this is also not. Acute schizophrenia and manic disorder. Okay. Manic episode. Manic episode, this could be. What about acute schizophrenia? Schizophrenia, is there any delusion? Is there any hallucination? Acute schizophrenia, there must be not only no delusion, right?
Yeah.
Is there any delusion? Is there any hallucination? He's not seeing something, no auditory, no, nothing is there. So this is also not his acute schizophrenia. This, the only thing left, manic episode, and you can also connect it to the fluoxetine. You know, fluoxetine has some side effect. If we are giving someone fluoxetine, we have to follow up the patient very carefully, because after starting fluoxetine, some people are having this kind of a episode like manic. He will be so excited. Okay, so this patient has a clue also with starting of a new drug of fluoxetine. That's why he's having this manic episode. Is that clear?
Yes.
Okay, so just let's read the most, as there was so much confusion with this question, let's read out all the three options. Most likely diagnosis is an episode of mania related to fluoxetine, okay, which is likely to reach peak effect some 3 to 4 weeks after commencing therapy. He was exactly started before 4 weeks. So they're telling when the medicine is at its peak, that time usually the episodes are coming. The overinflated opinion of himself as a savior of children fits well with the diagnosis. This is the delusion of grandiose, okay? Withdrawal of fluoxetine and institution of a medication more appropriate for bipolar disease are appropriate. So this time you have to withdraw that and you have to change it to another antidepressant. Acute schizophrenia is incorrect. It is less likely given with the proximity of the symptom to starting, because they're not, it will be not related with after fluoxetine, they will start acute schizophrenia. There is a cause, there is a precipitating cause. The age as at onset of symptom and the absence of delusions of reference. And also there is no other like delusion or hallucination. Usually schizophrenia question, usually in your part 1, they are usually given you hallucination type of at least one symptoms. Okay, so it will be easier for you, inshallah, to identify schizophrenia. Cocaine-induced, incorrect. Cocaine-induced associated with anxiety, paranoia, rather than just the delusion of grandeur. Okay, as I was telling you. PICS, this is the frontal lobe dementia. So this is totally different. Okay, clear?
Yes, madam.
Okay, so we will go to the next one, inshallah. Which of the following is the most appropriate next step? Cardiac resynchronization therapy, digoxin, increased furosemide, ivabradine, valsartan. Okay, 70-year-old man with a history of cardiac failure. Okay, another question from cardiac failure. Okay, so this is also very old baba. He came with a cardiac failure, came to the cardio clinic for review. He has suffered from decreased exercise tolerance over the past 5 months. Despite therapy, he's already on SE inhibitor, beta blocker, furosemide, same like before. On examination, his BP is okay, 128/80, pulse okay, regular, no AF. There is pansystolic murmur. There is a murmur. Loudest at the mitral area, crackles of both lungs, lungs base. There are minimal ankle swelling. So hemoglobin is okay, WBC is okay, platelet is okay, sodium is okay, potassium mild high, 5.1. 5 is the borderline. So 5.1 you can ignore, no problem. Creatinine also high because his kidney is affected maybe from this heart failure. Ejection fraction is low. That's why the kidney is ultimately affected. So ejection fraction here 30%. So less than 35.
Ivabradine.
Yeah.
Ivabradine. Yes.
Ivabradine. Because
Yeah.
of pulse 87.
Pulse 87. Very good. We are very lucky to have 2 questions. We are very lucky, alhamdulillah. So next time, inshallah, if any question from heart failure, you will never get it wrong. Okay, so we finish our Eva. I don't want to read it.
Ma'am,
Yes, Jay.
if that this patient have that Brady, then we will go for which drug for this situation?
For Brady,
Yeah. Now,
if Brady, then you have to search the causes of Brady, heart failure with Brady.
no. In this,
I mean, normal.
Here, for these options.
Yeah.
If
If it
increase furosemide if it is Brady.
I mean, you want to tell if heart rate is same. Then
No. Heart rate is less than 75.
Yes,
Then-
I mean
then-
normal, less
yeah,
than 75. Yeah.
Yeah.
Then you should think about sacubitril valsartan.
No, here there is
No option. No, because they didn't give this the answer. They didn't think of it. But the
Okay,
previously we just have that question.
Yeah.
No? So you
Okay.
can go for sacubitril valsartan over here.
Okay.
Okay, dear.
Okay.
And there is minimal actually ankle swelling. Sometimes even furosemide, they didn't give you the dose. Sometimes they are asking, this is part 2 question actually, not for you. I don't want to burden this. They want dose up for furosemide. But anyway, forget it. Whatever you don't need, just forget. Okay. So yes, what you are telling, if it is like normal heartbeat, but less than 75 heart rate, no, but normal. In that case, yeah, they will obviously give you sacubitril valsartan. Okay, dear? Okay. Which of the following is the most useful way to assess need for ITU, intensive care unit? No, this is the intensive therapy unit care. So DLC, OFEV1, FEV1 by FVC, TLC. A 45-year-old woman is a diagnosis of GBS. GBS is reviewed on the word. She has ascending weakness. If the weakness is going up, that has continued to progress despite a second course of IV immunoglobulin. So they have started the GBS treatment. One of your questions, they're asking also GBS. They will give you a scenario with GBS and they will ask you what is the treatment. So IV, IG, IV immunoglobulin we are going for. Okay. So you have been asked to see her because she complains of worsening SOB, particularly if she lies flat. On examination, her BP is okay, 110 by 70, pulse also okay, 75, and it's regular. She has 3/5 power weakness. She has weakness. It's 3/5, affecting both lower limbs. Is unable to sit up properly in the bed without help. Her chest is clear. Which of the following is the most useful way to assess she needs the ICU or not?
FBC.
Force vital capacity.
Force vital
First
capacity.
FEV1.
No, not the FEV one. With the forced vital capacity, you will know that the patient is having this respiratory failure or not. The same question also sometimes coming with myasthenia gravis. Any type of respiratory muscle weakness. Okay, so they are asking about even the FVC, this forced vital capacity limit, that at what level you should admit him to ICU and what level you should go for intubation. This is also important. So if it is less than 20 ml per kg, you need to send him to ICU. If it is less than 15, don't take the risk, go for intubation. Very important, and you need to memorize this 20 and 15. There are questions in part 1 from these two. Okay, so very, very important this thing. The question can be from GBS, the question can be from myasthenia gravis, or even they can give you anything that the patient is having the difficulty. They didn't give you the diagnosis of the patient. Just they will take you that the patient is
Like
Yeah.
MND.
Yeah, MND, very good. Yeah, even
Okay.
MND also they will give you. That patient is going to cannot because there is respiratory muscle also weakness will be there, right? So whatever the scenario, the question is usually these two. One is they will ask you what you should go for, and at what stage you should the patient should be admitted, and what stage their intubation you should go for. Clear? Very important for you guys. Usually I'm telling you that the numerical things not to memorize, but whatever needed, I'm always telling during my lectures. Okay, so this is important. This numerical, yes, you need to memorize, dear. Okay. Okay, so we will go for the next one. Where is the most likely interruption in the blood flow? Anterior cerebral artery, anterior communicating artery, middle cerebral artery, posterior cerebral artery, vertebral artery. 72-year-old man, a very old baba came. Okay, so present to the emergency department with a severe headache, vomiting, and drowsiness. He has a history of hypertension, continues to smoke 20 cigarettes per day. On examination, BP is high, 185 by 105. Pulse is okay, 85 and regular. He's complaining of a severe headache. So he's having severe headache. So this is also another thing. And mildly confused. GCS level is 13. There is right homonymous hemianopia. Initial CT scan is unremarkable. So this is which one? You are
Posterior
thinking
cerebral artery.
Posterior cerebral
Posterior
artery.
cerebral artery.
posterior cerebral artery because of vision, right? Whenever
Yes.
I cannot be included unless otherwise this is interrupting your post occipital part.